I'm David Moore, and welcome to the third annual conference of the Society for Digital Mental Health. We have 325 people registered right now, and like all technology conferences, you may have hopefully things are working okay, but our website went down for a little while this morning. Our host is having difficulties, so if I guess we will hope that all goes well in this for this webinar, but we beg your indulgence if there are any problems along the way. So the theme of the conference this year is evolving landscape, emerging trends, and breakthroughs. And the availability of generative AI is probably one of the biggest new things on the landscape, and we have today our keynote speaker, Alison Darcy, is going to be talking about generative AI and digital mental health. We have a number of poster sessions and flash talk panels, and we also tomorrow have a panel on the opportunities and the potential risks for generative AI and digital mental health. Implementation has also been going along this past year, even though there continue to be difficulties in sorry, I'm hoping that people can hear me. All right, let me know just the volume next to. I'm going to back off for a second, just a second. I'll be right back. Sorry, sounds like you could hear me. So I was just talking about the implementation. So we'll be talking a little bit later this morning about implementation and give some preliminary results from our implementation work group. Health equity has also been a big theme for this conference and generally. And there are changes coming. So I think a lot of us got into this, got into digital mental health because we want to provide mental health services to people who can't otherwise access them. And there are, emerging drivers for mental health equity in the system. So CMS, the Centers for Medicaid and Medicare Services, is introducing a health equity index in the 2027 star ratings. NCQA is exploring the integration of social determinants of health factors in HEDIS iterations. So this is starting, there are starting to be drivers for mental health equity in the healthcare system. And we have a number of poster sessions and flash talks on health equity. Finally, I want to say thank you all for completing the questionnaires that we have, including the post-session questionnaire from the last year. We do listen to those. And one of the things that came through was that people wanted more opportunities for interaction. And so we've increased that in a number of ways. One is that we've increased the number of Ask Me Anything sessions where you can go in and to an Ask Me Anything session, and there'll be an expert that you can ask, where you can ask questions. We've added Zoom networking meetings that cover a number of areas that people said that they were interested in some of these questionnaires. There will be flash polls that will be launched throughout the conference, and those you'll see in the lobby. That's in your browser. If you don't see the chat, there's a blue box in the upper right hand corner. Click on that and it'll open up, and if it takes over your screen, you can adjust the window size. And then finally, I just want to say, I know that these are a couple of long days, but I hope that you stay with us until the end. Tomorrow, we'll have a membership meeting at the end of the day, and we really encourage you to join. We'll tell you a little bit about what we're doing at SDMH, but we also want to hear from you about how the Society can support your interests, the interests of your organization, and if you want to get more involved in the Society, that would be a great place to start. All right, I'd now like to welcome Jennifer Greenberg and Hilary Weingarden to the stage here to join me. Jen and Hilary have worked tirelessly as our co-conference chairs, And I'm going to turn it over to you.
Thank you so much, David, and thank you to the board for inviting us to chair this year's conference and for all of your guidance throughout the process. We're extremely appreciative. If you could advance the slides, please. I'm not seeing the slides. You up there? Well, hopefully we can get our slides up, but we wanted to just extend a huge thank you to our 2024 Conference Planning Committee, who have worked extremely hard over the last 6 months to put together this extraordinary program. And we really could not have done this without your efforts and valuable input. A special thank you to Bethany for your absolute incredible guidance throughout the process. We really think you must be superhuman, and your dedication to the organization and the conference is unparalleled.
Bethany to the rescue, coming right on cue to
right
share.
On cue. Excellent. Wonderful. So again, huge thank you to the board. And then if we can show our wonderful planning committee. Again, thank you so much to each of you for all of the amazing efforts you've put into this year's conference.
And we also want to thank the conference tech support and communication teams led by Emma Wolf and Cesar Escobar Vieira, who've been working tirelessly behind the scenes to make sure that we've gotten word out broadly about this year's program and that the conference runs smoothly. So if you run into any technical snags during the conference today, reach out to both Emma Wolf and Lisa Palco and their team, and they'll help you.
And we also want to thank each of our moderators and networking hosts for volunteering your time to facilitate our conference sessions over the next 2 days. So again, thank you for everybody who has put together this conference. We're extremely excited about the program, and we hope that you very much enjoy the conference.
All right, and without further ado, we are now thrilled to welcome our keynote speaker, Dr. Alison Darcy, the founder and president of Woebot Health, to give this year's keynote address, Why AI Works for Mental Health Delivery. Dr. Darcy is a research psychologist and health tech designer who has reimagined how psychotherapy can be delivered for the way we live today. Her deep clinical expertise, pioneering mindset, and passion for accessible design are grounded in a 25-year track record studying and developing solutions that engage people in a therapeutic process. Dr. Darcy's training at University College Dublin, Stanford School of Medicine, and with the American Psychiatric Association, along with her experience leading AI pioneer Andrew Ng's Health Innovation Lab, helped her advance the shift from conventional face-to-face therapy to complementary AI-powered interventions. In 2017, she introduced the first scientifically informed mental health chatbot, Woebot, to make high-quality therapy radically accessible. Dr. Darcy is a vocal advocate for the safe and effective use of AI in healthcare. She also established the practices for Woebot studies and trials that have helped push the entire field forward and made Woebot Health the single most mentioned digital therapeutics company in the peer-reviewed scientific literature today. Named to the inaugural Time 100 AI list recognizing the most 100 influential individuals advancing AI, and the recipient of the 2023 UCD Alumni Award in Social Sciences, Dr. Darcy is also an adjunct faculty member in the Psychiatry and Behavioral Sciences Department of Stanford School of Medicine. Dr. Darcy, welcome. And she will now give her keynote. And if you have questions, go ahead and put those into the Q&A and we'll get to them after her address.
Well, thank you so much for that introduction. Yes, I don't know what to say. I hope I live up to that introduction. Can you all hear me effectively, or is there an echo? I'm just wondering. While I bring up my slides. Hopefully you can all see this. Okay, well, it's an absolute pleasure to be here today to present to you. And I'm just kind of share a little bit about our journey. Okay, thank you. I'm just trying to figure out this echo. Okay. Bear with me, folks. Is that any better? I think we got it. Okay. Thank you. And thank you for your patience. Well, as I was saying, it's a thrill to be here today. So how are we doing? I think this is all moving. So until I hear otherwise, I'll just keep going. But is there still an echo? Okay. I'm not hearing it. So yeah, as I said, I'll continue. Here are my disclosures, folks. As was mentioned, I founded Woebot Health, and we're lucky enough to receive some grant funding from the National Institutes of Mental Health. Okay, so one of the things I get asked all the time that I really don't find I have a very good answer for is sort of what is Woebot? And you know, in 2018, Clive Thompson wrote this article in the New York Times Magazine, where he actually positioned sort of conversational AI as an interface metaphor. And so he said, before the Apple Macintosh, the first computer to popularize point and click, people using home computers had to familiarize themselves with abstruse text commands. And the advent of the visual interface opened up computing to the masses, producing a generation fluent in word processing, email, and eventually web surfing. The next great shift, of course, the mobile phone, put computing and nonstop internet access into our pockets and unleashed a tsunami of social media. Talking software or conversing software gives us computers that not only ride along with us, but also socialize with us. So being human-like, saying hi, telling self-deprecating jokes, this is their interface metaphor. Much as the first point and click computers used the trappings of office life, a waste paper basket, a tiny notepad of paper to help orientate us to the screen. And he said these sorts of changes don't come along very often, but when they do, they create new and unexpected behaviors. And I would say at Woebot Health, we're really obsessed about what the new and unexpected behaviors that might emerge from this human-computer interface might be. And that's, of course, a key theme throughout the research that we do. I was actually sitting at on a panel on Saturday with a gentleman called Pedro Campmany, who is he's actually a musician from Costa Rica. And just in terms of this theme of what new and unexpected behaviors might be emerging from this new form of technology that we have. His father sadly passed away when he was just 13 years old. And his father had been a very successful, very famous musician in Costa Rica as well. And one of his lifelong ambitions was to be able to sing alongside his dad. And given since generative AI has emerged into the scene in the last 24 months, he actually had the opportunity to record a new song effectively with using the voice of his father, and to sort of realize that lifelong ambition, which I just thought was sort of a very moving example of how there's kind of very new opportunities that I don't know that we've even truly fully considered yet, that might emerge as a result of this technology, and things that are quite fundamentally human in our experience as well. So, of course, the other thing is we're in peak hype cycle, I think at this point, it's fair to say. Actually, I've heard recently some people think we're not even in the full hype yet. But when we're in a peak hype, there is a lot of focus on when things go wrong. And there's also, peak expectations of where this technology might take us, even though we're very early on in our journey. But it's interesting in the field of mental health, of course, we already have a very strong template for the role that this technology might take in our lives. And, and every one of us in this room will have had this experience whenever we say the word psychotherapy or mental health treatment in any room. Of course, people conjure this some version of the image you see before you. Classic Freud, somebody lying on the couch. In this depiction, he's not smoking a cigar, but all of that comes to mind. And that has both helped and hindered us, I would say, in the development of this technology. I mean, this is so ubiquitous that I would say anytime Woebot Health has been mentioned in the news, there is some version of this scene, but a robot in the chair instead of the Freud, and instantly people understand what that visual metaphor is saying. However, it's leading us down, I would say, an incorrect road, because it's inappropriately setting up this replacement narrative that AIs are going to replace all therapists. And of course, it could be further from the truth. AIs are there to augment and facilitate and really, I think, elevate the role of the human to human therapist relationship. And AIs are there to sort of help therapists be amplified at the times that the human can't be there. And so much of us understanding and developing in this space is about understanding kind of the core elements that make us human, and insofar as they feed into a positive therapeutic relationship, and also the key elements that enable or offer key advantages for the digital agent, if you like, or the AI. However, I would say one of the benefits that, having such a key kind of framework for us as we develop technologies for mental health treatment is the fact that the role of the therapist and how the therapy is developed really is informed very deeply by the specific role of the psychotherapist. And this actually varies according to, the psychodynamic or the psychotherapeutic approach. So, for example, at Stanford, I was trained in both behavioral family therapy and systemic family therapy. And the ways in which the therapist shows up in both of those therapeutic approaches is really different. So in systemic family therapy, the idea is that you join with the family and you become part of the system, such that because you can't really comment on the system if you're not acknowledging your part in that system. Whereas behavioral family therapy, in that role, the therapist is very much a consultant and an expert in the illness, but empowering the parents to see that they are the expert in their child. And empowerment is really core intervention that the therapist is tasked with enabling in that setting. Similarly, I think of things like 12-step programs, which are really interesting. They are explicitly non-professional networks wherein recovery role models, people who have successfully managed their alcohol or substance use program, represent what life can be for folks who are much, much earlier on in their journey. And there's also, of course, things like sponsors in those 12-step programs where people, can be there for somebody, a trusted relationship at a key moment of need. And that's really special. And it's something that is explicitly not part of our sort of professional services in the way that they've been developed to date. In cognitive behavioral therapy, which is the approach that Woebot is based on, and so much of the digital therapeutics are based on CBT. The relationship is characterized by what Beck called collaborative empiricism, and so coming together as sort of more equal than a great power differential, and to look at kind of what data the person can bring to the table as a way of painting a picture of their worldview and how that worldview may or may not be serving them, or may or may not be sort of free from bias that we see when people are suffering with depression in particular. There's also kind of interesting, I think, angle to this. We in 2021, I think, a fantastic anthropologist from Oxford University wrote an article as well about his experience using Woebot during the pandemic. And when I talked to him on the phone, his opinion, the angle in which that he saw immediately was the sort of sociological or anthropological, in that he felt that modern and contemporary cultures just don't have a lot of the roles that may have existed before. So things like, you're the sort of priest in certain countries where, religion is declining, but also kind of the shaman, the Madala, the sort of the wise elders, if you like, that were tasked with sort of receiving the disclosures of people in the community. And of course, we're seeing communities shift very dramatically as cultures become more urbanized, and our kind of modern technologies sort of seem to kind of take over a little bit. And so he felt that it made sense in today's digitized society that, AI, or certainly our technologies, may be filling some of these gaps, not in the same way, but I thought it was an interesting angle nonetheless. This lady that you see before you, this is Peg Sayers, who is a Shanachie, or a storyteller in Ireland, which was part of the culture here, very strong sort of oral storytelling culture. Storytelling as a way of passing knowledge down from generation to generation in very oral cultures. And I would say that that's also a role that we have somewhat lost. And it's interesting because this is the dynamic that Woebot adopts when sort of teaching something from a core curriculum of psychotherapeutic constructs, the sort of psychoeducation piece. Now, I think when we're looking at sort of how we're developing Woebot, we of course are looking at what are the elements of a relationship. So really clear to say from the outset, we do not believe that we're building something that's a replacement for human relationships, but we can nonetheless look at the literature about the elements thereof that might affect outcomes and see if there's a way to develop the technology in a way that gives rise to some of those elements. And actually, a couple of things, there's a lot of things that are well known to be helpful, right, when it comes to outcomes for human relationships in a therapeutic context. Of course, empathy, trust, human, good manners, and a strong relationship between working alliance and health outcomes. These are all elements that are well understood to influence better outcomes in traditional human delivered care. Similarly, I think there's been some work, and mostly coming from Tim Bickmore's lab, on AI agency. They have empirically looked at agent behaviors and sort of elements. And when I say they've empirically sort of looked at these things, there's been a lot of work, really, really beautifully done work, where they look at to build, have built AI agents that, you know, are very similar to the other one, except, you know, don't have, you know, strong empathic statements, or, you know, where they've sort of tweaked or toggled on and off various elements to look at their impact on health outcomes. And so there's also a reasonable literature here as well that informs what AI agents should be, how they should conduct themselves. And it turns out a lot of it is very similar to what we know of from human relationships: empathy, trust, humor, good manners, or what's known in the field as continuity behaviors. They're all there. Things like personal disclosure. So interestingly, people have better outcomes and have more trust an AI agent that discloses something about itself, even when they know that this is not a real entity. It just turns out that that's sort of the way that humans are hardwired. So I think that's interesting. I think there's an awful lot about human relationships that is also poorly understood. I think the sort of the right patient therapist attribute mix is something that's not very like it's an early it's nascent in the literature, and there are a lot of, I think, companies that do that well. And also, I think the coaching dynamics and certain identity factors and the right mix there as well. Similarly, there's a lot of unknown in how AI agents should conduct themselves. So things like passive versus active data collection. This means sort of listening to you, if you like, or passively tracking certain behaviors on the phone. We've had interesting conversations with users about this. Some people want Woebot to track their sleep, others don't, and feel it would be creepy and a violation of the kind of construct that Woebot establishes. And then, you know, as I said, one of the most exciting places for this technology to be developed are thinking about what new and unexpected behaviors or opportunities this human to computer interaction may create. And we believe strongly that there will be opportunities for sort of psychological mechanism that can be delivered through this conversational medium. Quick word here, many of you will be very familiar with the Wompold study that looked at kind of what are the three major pathways to therapeutic benefit. And the Wompold concludes that there's the real relationship factors, there's treatment expectations, and there's also enactment of health promoting actions. We've also seen similar trends in our data. Indeed, we could see that enactment of skills that Woebot is taking people through influences outcomes. And of course, as I said, that what we've just looked at are the kind of relationship elements that are really important and impactful for outcomes. I worry about the third one, and expectations. And I, in all of the conversation around where this technology is going and for all of its risks, which are real, I worry about a sort of a lack of regulation and a lot of apps on the market that make claims without necessarily the data that supports them. And that includes us. And so as we drive towards a future, or like of a tech-enabled future of mental health care treatment, I think it's really important that we don't undermine the public confidence in what could be, I think, a really key public health opportunity with this technology. So this brings me to Woebot. Why did we create Woebot? Really, for me, Woebot was a way of addressing what I thought was the key problem, which was actually engagement. So there had been a very good literature, there's over 20 years of data that supports that the idea that we could build digitized cognitive behavioral therapy experiences, and that have done pretty well in trials. But I think there was a couple of problems with them, and most notably is the challenge around engagement. And I thought, you know, if we can't engage people, then, you know, it really undermines your ability to get good outcomes, right? Because you obviously need people to get a sort of a dose, a sufficient dose to get well. The other issue was that the data was pretty, seemed to indicate that where a human is in the loop, it leads to better outcomes. And this was in the sort of self-help and guided self-help literature. But I always felt, and certainly from when we did the first study with Woebot, and we saw qualitative reactions from people saying things like, you know, that they appreciated the accountability that Woebot was bringing to the table, and it felt more like a friend than an app, checking in on them every day. That, coupled with the sort of engagement data, made me think, you know, maybe we can actually deliver some of the things that a human relationship delivers while expressly not being a human relationship, right? And could that lead us to towards a better pathway for better outcomes? Could we actually squeeze as much efficacy out of purely digital solutions that we can, because we are definitely going to need solutions that can scale, particularly in the early part of people's journeys, if we're going to lower the burden of suffering at population level. So not because I don't believe in humans, I really believe in humans, but because I thought maybe digital solutions were not fulfilling their full potential. And so that's why we built Woebot. We ultimately, we made a lot of prototypes. We went through a lot of little CBT themed games, because again, the thesis was engagement. And then games, I would say, were loosely defined. But ultimately, when I made a relational agent, you could see immediately that people just found it a very natural way to interact and to answer the question, how are you? Even when they're upset. And I think that's the key opportunity, is can you engage people in the skills that help them in those moments when they can get most benefit from being able to engage in those skills, to build empowerment and so on. I would say that's been the key. The thing that we've done best, I would say, is a technology that can sort of reach you in that moment. And our data really supports this, just our usage data, that most 75% of all of the messages that are sent occur outside of clinic hours. So after 5 p.m. and before 8 a.m. the next day, and at weekends. And of course, so these conversations are nowhere near what you might have with a human friend or therapist, but they are nonetheless important moments in which, if we can engage people's own resources to feel better, we should, and just get them right back into feeling, into their own sort of day-to-day lives. Always supporting talking to other humans where possible, and always supporting sort of a re-engagement in everyday life, not necessarily keeping people in the conversation as long as they can. So this is just some data around one of our recent deployments in New Jersey with Virtua Health, which has just been a fantastic partner, and just this is real world kind of utilization. And yeah, we find people really like the content. Obviously, there's a sort of a high activation rate after a clinician recommends Woebot. And again, almost 80% of those conversations happening outside of clinic hours. So, quick word about the science. To date, we have conducted about 18 trials. Now, not all of these are published yet, but they do cover more than 2,000 participants. We have had quite a few peer-reviewed publications and presentations at this point. I think it's about 15 papers, and one of the things that Dr. Athena Robinson has done, our Chief Clinical Officer, has really driven from the very beginning, is an embedded sort of attention to health equity in the data collection and the research methods, which which is paying dividends now. I would say we can say things, we're seeing kind of interesting and nuanced novel findings around the way some traditionally marginalized communities react to Woebot, and that is just, it's very satisfying, and it's a really good encouragement to continue to sort of oversample for folks that might normally be considered minorities, and are certainly sort of tended to be marginalized or disenfranchised, would not have been, I think, included in traditional service build and traditional service development in over the last few decades. Some of these I would I think basically a summary of this quite busy slide is that this kind of thinking must be integrated kind of through all levels of the company. So not only sort of recruiting, from diverse groups and including, as many, kind of diverse folks as you can in your company, because of course there's always some element of the imprint of the maker on the product itself. But from recruitment and enrollment in particular, we've seen that investment in, trying to recruit from more expanded sources, say, than traditionally considered, has really paid dividends. Specific partnerships we've entered into so that we can have a more representative pipeline and funnel for research, for scientific research, has really helped as well. And then I think Dr. Robinson has really pushed the needle on things like, what are the ways in which that we are gathering sociodemographic information, and is there any consistency across the literature, and how can we do better? How can we actually meet people with more representative and more inclusive way of just assessing even for those demographic differences? We always tend to look at subgroup. In our exploratory secondary analyses, we'll always look at subgroup outcomes and compare them across as many studies as we can. And of course, just an active commitment to sort of sharing our findings, both registering our trials ahead of conducting them, but then publishing findings, and of course, being vocal as well in presentations. So a couple of summary findings here. I think for adults, we find a fairly high adherence rate to the interventions that we deliver, about 65 to 79%. And these do tend to be stable across groups. We've a consistently good sort of high record of recruiting people from traditionally underserved areas, or areas where there is a mental health provider shortage. And when we have modeled sort of things like some of the, Valerie Freeman, who's our head of intervention science, has done a beautiful job of sort of modeling different usage patterns with the larger data sets that we have, and has found some really interesting things around the different ways in which maybe some subgroups engage with Woebot. One of the more exciting is that non-Hispanic Black participants had more favorable wellness outcomes, even if they start in a more difficult spot than non-Hispanic white participants, and are a group that we would call efficient users. So have a kind of a steep reduction in wellness, or steep improvement in wellness outcomes. And yeah, these efficient engagers, when we looked at the demographics, tend to be young, male, non-Hispanic Black folks who don't have insurance. Why that's exciting for us is that this is a group that will, tend to not show up in clinics, right? And then, of course, are not included in the data. And that is a kind of a self-fulfilling prophecy. And, it's really nice to see some technology, if we can build it, that has the potential at least to transcend maybe some of the traditional sociocultural baggage associated with research and health delivery. This is just the beginning, and obviously AI has its own issues around bias in the data sets, and so we think this is just kind of table stakes for all companies involved in any service that's built on AI. We're going to have a very close look at what comprises the data sets to ensure that they're at least representative, and we would argue more than representative, over-representative of what would have been traditionally sort of marginalized groups. Are some of our adolescent studies that are currently in preparation. We've seen some of the most diverse samples yet in terms of gender, race and ethnicity, and sexual minorities as well. And in maternal health, I think this is a really key thing for us, because things like postpartum distress tends to be overrepresented among people of color in the US. And so it's so important that we're able to represent those folks that are typically underrepresented in biomedical research, and sort of start to tease apart the effect or the potential that Woebot can have. Finally, a word on, I'd like to say that we were doing AI before it was cool, but, important to say that Woebot is not a generative chatbot right now. So everything Woebot says has been crafted by our team of writers under the supervision of clinical psychologists. And so we became very interested. Obviously, generative AI offers this incredible new set of tools, but it has not been without problems. And I think just representative of the way in which we tend to proceed and develop things is sort of like, okay, let's study it. So Tim Campolone, who heads translation science at Woebot, conducted a registered trial where he looked at a rules-based sort of expert system version of Woebot, which is Woebot as it is today, versus a Woebot that was infused with large language models and generative AI, although without the generative components. So we still had a sort of a safety architecture in place, which meant that the participants in the trial were not directly interfacing with a large language model, which is what ChatGPT and other things are built on. And so this study was a really interesting kind of validation of that safety architecture as well, and those guardrails. Interesting to see, I think we've just published this, but we didn't find the primary outcome of this study was just user satisfaction and like the user experience, if you like. I think there's been so much attention paid to like accuracy and the technology itself, with relatively little attention paid to the human experience of things like ChatGPT. And what we found was that it was interesting. We didn't find any difference we couldn't find evidence of difference between sort of satisfaction or user experience, even when we could see that in some places, some algorithms that were using large language models, which are very powerful, were sort of outperforming by 100, like they were dubbed twice as accurate as some of the other algorithms running in Woebot, and still users didn't seem to detect the difference. So in both arms of the study, folks believed they were more likely to believe they were in the generative arm. And so we started racking our brain thinking about this. And it sort of made sense when you think about the psychological tools that we're delivering here. I think a lot of generative AI has been built to sort of give an answer. It's a transaction and they're optimizing for a correct answer. Whereas I think what we're building here is a good process. A good Woebot should be asking you the right questions or asking the user the right questions so that they're facilitating a process, but they're not becoming part of it. And I think there's also kind of elements of humans tend to think of the gestalt. So it didn't need to be a perfect experience. People perceive it to be a perfect experience anyway, nonetheless. But also I think, just the way the conversation has been constructed, there's there's a sufficient sort of, dare I say, magic, but there is it does feel very good, and when it's working well. And I think it's a testament to our sort of conversational designers, the way they've constructed the conversation. It's just a conversation that works and is hard to improve on with some of these generative tools. And so we think the opportunity might be elsewhere. Finally, I just want to leave you with this before I open up for questions. This is a friend of mine, the brilliant researcher Adam Miner gave me a copy of this book. And this was, of course, Joseph Weizenbaum's book, in which he describes Eliza, the first chatbot that he created, and was very, I would say, shook by the reaction watching one of his colleagues interacting with Eliza and sort of asking to shut the door so that she could have alone time with Eliza. And I think he was quite unsettled by this, and there was a lot of controversy at the time about what this might mean for fields like psychiatry and so on. So this isn't, I would say, new, but in the chapter of this book where he describes this, there's a footnote written by Carl Sagan. And I always like to end a presentation with a Carl Sagan quote. I mean, who doesn't? But he says, no such computer program is adequate for psychiatric use today, but the same can be remarked about some human psychotherapists. In a period when more and more people in our society seem to be in need of psychiatric counselling, and when time sharing of computers is widespread, I can imagine the development of a network of computer psychotherapeutic terminals, something like arrays of large telephone booths, in which, for a few dollars a session, we would be able to talk with an attentive, tested, and largely non-directive psychotherapist. I think that's amazing. He wrote that in 1975, and here we are today. So I will leave there, folks, and answer some of those questions. Thank you so much,
Alison. What an interesting talk. And I'm just going to pull questions for you from the Q&A. So if you have audience members, questions for Dr. Darcy, feel free to throw those into the Q&A. So the first one is a multi-part question about engagement. So how do the folks at Woebot operationalize engagement? Do you think the concept of engagement varies or should vary between industry and academia? That is, do you think engagement is best defined locally according to the platform used? Is there a use in defining and evaluating engagement in a universal construct for digital mental health interventions?
So I'll give you some thoughts specifically around engagement. I think we are evolving how we think about engagement. I can tell you straight off the bat that this is not about daily active users and retention over time. I do believe that there is something about what is the meaningful engagement. I think we look at a construct of potency, not engagement. So what are the correct types of engagements that are most likely to bring about change in the least amount of time? And that also feeds into kind of what your principles are. And I think a key principle for us that is, of course, the antithesis of a lot of technology today is that we don't want people to be talking to Woebot for endless amounts of time or for endless amounts of, macro time either, right? You want Woebot to be potentially a trusted relationship that someone can feel that they can go to in a moment of need, that is trustworthy and is likely to be able to help. But you don't want them just checking in for the sake of it. And that is something that's how we've built Woebot. And that is something that users email us about all the time and say, my goodness, it's almost sort of retreating constantly rather than, advancing with, push notifications and things like that. So I do think this is a very early stage. I think Valerie has done some incredible work and thinking about this, and there's some interesting work happening that's emerging. And happily, I think the people that support Woebot's development are also on the same page, that this is not technology kind of engagement. Those metrics do not apply in healthcare, and you really can't come to a decent definition of engagement, I think, without looking at what is the thing that you're trying to give rise to, right? What are we optimizing for? Human health, human health and human advancement, not, and certainly not attention, right? That we've already gone down that road with various technologies, and it definitely has not worked out well for health. I don't know if that really is a clear answer. I'm happy to talk about this in more detail, but that's just, an overview of how we think about engagement.
Very interesting. And pivoting to a different question. So are you seeking FDA clearance for Woebot, and when do you expect it, if so?
Yeah, we're definitely, we are pro regulation and the timeline is difficult to provide, but yeah, we believe in regulation, and that's the interesting thing that's emerging right now. And I think there's some really wonderful people at the FDA as well who are thinking through how a technology like this should be regulated in a way that sort of also allows for innovation. So yeah, I would say, watch this space for sure.
Absolutely. And for others who are interested in regulatory pathways, there will be a breakout networking room later today for folks to talk about that in more detail. Was Woebot covered by insurance for the participants in the studies you covered, and how were the participants selected?
That's really interesting. I'm not sure which study that we're referring to, but they mostly we're agnostic to insurance cover. So we actually have both folks that we're recruiting, both people who are in insurance and who are not. Usually our studies are not coming through an insurer, however, with the exception of where we've kind of shown data in a specific context like virtual health, and that's obviously the exception. But for most of our academic studies, we are not recruiting through an insurer, no. So it would be a mix, but we do. And that is a variable that we are capturing.
And how best would your interventions be customized to be culturally appropriate for different settings?
Oh, this is the great question for us as well. We've looked at localization in terms of language, and of course, which is much more detailed endeavor than just a straight up language translation. So there's a lot more cultural translation as well. I think a key sort of initial out the door principle that we have adhere to is sort of trying to build for the universal human experience rather than being exhaustive. So universal over exhaustive, which means if there's an opportunity, you're addressing what is a universal human experience without talking specifically about the sort of variations thereof, because actually that's, especially when you're looking at a tool set like CBT or something, right, there's a universality to it, and almost like an art form in applying that universality or explaining that universality of principles across, the problem spectrum. So that's just a much more detailed question, but I think it comes from the data. It comes from the data as well, right, where we have, and then the data that we're seeing, but also mostly the interviews and conversations that we have with people with lived experience as well. So that deeply informs any iteration of an intervention that we're building for, would include a long process of talking to people with lived experience.
And can you talk more about the scope of mental health issues that Woebot is designed to handle?
So primarily it's under enforcement discretion. It's, symptoms of anxiety and depression. We are agnostic to diagnosis, but in the course of a single encounter, we are addressing the kinds of problems that people sort of bring to the table, right? Instead of, we've never had, or it's, well, so this can be anything from, financial concern to, loneliness to grief. And, it really depends on what the person is bringing at that moment. In those moments, it's very rare for someone to actually say, like, I need help with my depression. What they're saying is, you know, I just had an argument with my partner and I don't know how to manage this and I'm furious, and or like I just miss my mom, or, you know, and so we sort of share tools and skills inspired by CBT in those moments, adjusted to that specific problem, because it's about sort of reaching people in the moment, not really addressing an entire diagnosis, if that makes sense. Just a kind of a nuance in how we've developed Woebot.
And a somewhat related question, but how do you approach risk management within the chatbot? So someone disclosing SI, for example.
Yeah, well, it's sort of multifactorial, if you like, and it starts from the very first encounter. So in onboarding, we're really clear, and we have every user acknowledge that Woebot isn't a crisis service, and that we make sure that everybody understands that there's nobody potentially live there, because we don't want anyone to think that we could respond in the moment. But then Woebot's task is to, when they detect some concerning language, to make sure that we're clearly communicating, this is kind of reaching the limit of what I can do here. And so then Woebot in that moment would offer sort of a list of curated helplines that we've created in conjunction with sort of, suicide prevention experts, but also, yeah, remind the person that, and encourage them to sort of, you should talk to a human here. This is like something that I can't really help with, and it's, you know, it's beyond what I can do. So then we, of course, are monitoring the accuracy of that concerning language detection all the time, and in every partnership context as well.
Makes sense. And maybe one or two more questions before we wrap up. So how is Woebot adapted for adolescents? What was the adaptation process, and what adjustments ended up mattering?
What a great question. So there's again, it's sort of it's multiple tiers, I would say. A lot of content adaptation. So Woebot is discussing things that wouldn't necessarily arise for adults, for example, or wouldn't arise for adults in sufficient velocity, if you like. So things like going through a parental divorce, you know, we would see a lot of that kind of thing, bullying in school settings, body image, media literacy, those kinds of things Woebot will touch on. That also means that Woebot's algorithms and ability to detect those kinds of problem areas in the moment are a bit more tuned to issues that adolescents are bringing to the table. And then, yeah, we're constantly open and interested in other modifications, but they're the ones that come to mind now. Yeah. They're the ones that are coming to mind. I know I'm missing something. But we get asked that question all the time. So yeah, please do reach out for more information about that. Yeah.
And again, a plug for our networking breakout rooms. But if you're particularly interested in adapting digital mental health for adolescent populations, we have a networking breakout room geared towards that topic later today. And I'll close with one last question for you. And thank you again. This was so interesting. What are your thoughts about, and you spoke to this a bit, but what are your thoughts about how companies can police themselves from an ethical design perspective, and on what needs to happen at higher levels to ensure ethical designs?
Gosh, that is a great question. I've been really inspired by, I think the GDPR, this is the sort of privacy data protection policy that's active in the EU. There's a notion of privacy by design under GDPR, which means that you've got to show that you're, and this is just in the example of privacy, but you've got to show that you are considering data privacy issues at the design level. And we think about it that way. So our sort of ethical construction and design elements are sort of built into the product development process. And are documented therein. And, I think in the earlier stage of the company, of course, you need to hire people that share your values, right? And one of the key values that Woebot was built on was a belief that, hey, people in this area should be doing science, like we should kind of be checking, right, that the thing that you're creating is having the effect that you expect it to, and it's certainly not having any unanticipated effects. And if it is, that you're managing that. But I think now, at a sort of later phase in the company and a different stage of maturity, it's actually really has to be sort of written into the quality management system, the actual manufacturing process, such that it's something that people don't have to actively think about. It's just there. It's part of what you do and how you do what you do. And I think that's something that we didn't expect to be such a differentiator, but it turns out it is things that something that people care about, as they should, right? As we absolutely all should. And interesting, and I will just leave with the final thing about this, is that our users are discerning. So that's something that we've actively sort of spoken to users about as well. And they are also looking for companies that have taken the time to do the studies, because as we all know here, that is not the easy path or the short path, but it is important, and it's important to the end user as well, which I think is a good thing.
Absolutely. Well, Alison, thank you again. And we're now going to take a 10-minute break. We will be reconvening at 12:10 Eastern Time for a featured presentation by the Society for Digital Mental Health Implementation Working Group. And so we'll see you then.
Thank you.